Yeah. Okay, so hello everyone. I hope everything's good. Today on the seminar we have Dr. Abdelrasek Serai joining us again for the seminar on, combining the seminar from Tuesday and from today, which the one on Tuesday was on imaging, morphology, function, and perfusion. And then today's on flow mapping and vessel imaging. And yeah, he's from Philips, Tunisia. And yeah, I guess the floor is yours. Can you share your screen? Wait 1 second.
No,
Loud.
I'm disabled. Just
See.
able me to zoom. Yeah.
Every time.
Yeah.
Okay, sorry. Now?
Yeah, it's okay. Yeah.
Great.
Yeah, fine. Oh, I think. Yeah. Hello, everyone. Here I want to try in this session to explain several parts with different stages of cardiac MR. Of course, I will explain the CNE study, morphology, and the delay enhancement study. Also, how did the cardiac perfusion, also for the sequence and the post-processing for the delay enhancement. I will give also how we can do the flow study, also the mapping, the T1 and T2 and T2 star mapping. And I will close with the coronary analysis. Note that in each part during this presentation, I will explain physics of MR and used as well as the adapted sequence. In addition, I will put the dedicated processing for each session. So let us start by the CNE study, in which the main objective is the study of the contraction of the heart muscle. CNE sequences are employed to assess cardiac function. During CNE acquisition, multiple individual images are captured at various phases of the cardiac cycle. These images are then delayed as a CNE video, providing users with a visual representation of the cardiac activity, of course. In Philips, usually we use the balanced fast field echo sequence. Similar, for example, when some users use Siemens, they use the TrueFISP. It's very strongly sequence, and it's very recommended for the CNE imaging due to their high temporal and spatial resolution, as well as improved for the blood tissue contrast. Here, the CNE for the short axis, for example, here you can see the fourth chamber, the right and the left ventricle, also the right and the left atrium, also for the different valve, metric valve, for example, or trick speed or something like this. So here it's a CNE for the two chamber. Yeah. The CNE study is a study of the segmental kinetics of the walls of the heart. Also, it gives us the global kinetics of the heart, like fraction ejection for the ventricle left calculation. It's the give us also the study of the cardiac mass, also the study of the valvular pathology. These are therefore a sequence carried out most of the time in retrospective triggering in order to be able to study the entire cardiac cycle and in breath holding. These are, like I said, most commonly balanced fast field echo sequence. For the balanced FFU, there is also called echo of gradient with equilibrium state and balanced gradient. Therefore, there are an intermediate sequence between the gradient echo and the spin echo. It's a sequence with T1 per T2 weighted signal. When we have some precision speed in all directions, we get an appropriate signal. It's very important to overcome the phase shift of the flow, for example, with a constant speed. And the application of a balanced and asymmetrical gradient in the three direction of space make it possible to overcome phase shift of flow at a constant speed, like I said. The balanced character indicate that the positive and negative lobes of this gradient are in equal quantity. We obtain a sequence with T1 pair T2 weighted signal, good signal, of course. When we distinguish between blood and myocardium contrast, we note with white blood if all the proton or spines have the same precision speed in all the direction, we can get a good signal or an impaired signal. Yeah. Just in the setting, the user must check the phases, the fold over direction. It's always we make right, left, or anterior, posterior direction. Never use in foot head phases. We can get some motion artifact when we put foot head phases. Here, an image of the right left phases. You see the two chamber, it's very clear and very distinguished from the left ventricle and the left atrium. Also, check the size of the valve. Do not hesitate to increase the oversampling to get out of the patient in order to avoid the folding. Like I said, artifact of the folding. Just get max of fold over max of the size of the fob. Yeah. You can get in the geometry tab in Philips to increase the oversampling value if necessary. In the apnea, for example, if the apnea time increases too much, important slightly increase the SANS or compressed SANS value factor by 2 or 3. Can use 3 or 2 to get more signal to noise ratio. Also, the placement of the volume scheme should be well centered around the heart, including the aorta. It works in 90% of the cases. Here, the image with good contrast. In event of strong acceleration, for example, when you use in the mass of 3 Tesla machine, or just place the shim, the shim volume on the area distributed by an acceleration significant flow. Here the image of the scene. Yeah. Always check the quality of the electrocardiogram from which follow directly the correct detection of the air wave with the red line here. So in cases we can get a good air waves, then in this case you should start a new calibration. The temporal resolution, it's called turbo field echo. Should duration must be less than 45 milliseconds. Just here to verify generally, just when we use, for example, more greater than 23 phases, just we can use must be less than 45 milliseconds. So as not to underestimate the left ventricle ejection fraction. Check it in the info type. The users who use Philips machine. Just you can see it in the info tab here. Yeah. Otherwise, increase the number of the cardiac phases in the motion because it's very important here a step to get much more signal to noise ratio. Also for the TR as short as possible, and for the TE it's equal by the TR divided by 2. So the post, considering the post-injection contrast optimization, trying to increase the flip angle by approximately between 60 to 80. Note that when we increase the flip angle, there are also the increase in the SAR physiological parameter. Yeah. Here we can see some picture in the cine. There are here the leak of the aortic valve. It's considered that's disease. Here there is for the mitral stenosis, and there is here a very normal aortic valve. This is the, also this normal picture. For the post-processing, there are main two methods are carried out in particular on the ESP and space when using cardiac MR analysis. The aim of these two methods is to calculate the ejection fraction of the left ventricle and the right ventricle by comparing the cardiac volume in diastole and systole, as well as several resultant ratio, in particular, for example, the cardiac mass. Here for the Philips users, you know that this application is dedicated for the cardiac MR analysis. The first method is the Simpson method. It's the widely used method in the MRI. And the last one is the Alif method. It's used, for example, for the ultrasound, but we will concentrate here about the Simpson method. The Simpson method, it's based on the fact that the volume of a complex 3D model can be quantified by cutting into small slices, adding to the volume of each separate section gives the total volume. This calculation is done from so-called multi-slice, multi-phase cine, going from the valve to the apex in short axis. In addition, this method makes it possible to calculate right and left ventricle volume. Yeah, here we see the post-processing for this method. Just we start by choosing the short axis, the function, and launch the short axis series and launch the cardiac MR analysis you see here in the video. Just we will look for this video to understand how we can do the post-processing. We launch this application. After that, we check and correct the labeling in the plane if necessary, of course. Here we see the long axis for two chamber and long axis for four chamber. And we click here in the labeling. We can get two image. Yeah, here we see the image. We do a right click on the image and start the MR cardiac analysis. Right click here in the image and we pull down to launch a start analysis application. Yeah, he just talk about the number of series which are perpendicular. So we choose the diastole and the systole in the two chamber and the fourth chamber. Yeah, we have here the diastole in the two chamber and the diastole here in the fourth chamber. Also here the diastole, the systole on the two chamber and the systole in the fourth chamber. Yeah, just take a look about and to be sure for the anatomical details about the two chamber and four chamber. Choose the most basal slice. Choose the most basal slice in the two chamber and the chamber and try to draw some undo contour for the and diastole and try to the undo for the four chamber also. Just here we can draw some undo contour. And also for the systole, you can get drawing and an undo contour for the systole for the two chamber and for the four chamber. Yeah. And also we can go for the segmentation to check the results. Yeah, we can get a table that's all the features from the cardiac in the left ventricle, like fraction ejection, stroke volume, cardiac output, stroke index, cardiac index, and diastole volume and systole volume. Also, we can set the BSA parameter to put the height and the weight of the patient. Yeah, to make the weight and the height of the patient. It's very important. Of course, in all series, in the diastole and the systole for the two plane for the two chamber and four chamber. Yeah, after that we can get the image and this the summarize of the results, especially the ejection fraction. For the next method, this so-called surface land based on geometric model. The left ventricle is linked to an ellipsoid of revolution. So the volume of the left ventricle is given by this formula. So if we take the measurement in systole and diastole, we can obtain the left ventricle ejection fraction. And in order to minimize the approximation of the measurement, the calculation can be carried out from the two perpendicular planes. Yeah, we can get the two chamber and the four chamber, and generally we measured using two multi-phase and with a single slice cine. The first it's into chamber, and the second it's with four chamber. Now just we will I will give the morphological study. The objective of this study of the morphology is to have an idea or some information in diastole of the heart muscle. We can use some sequence like a T1 turbospin echo black blood or T1 spare black blood, T2 spare black blood. This is the sequence. I will explain them later. And T2 steer black blood. The two black blood steer or spare depending on preference. This T2 in case of suspicion of myocarditis in order to highlight the presence or absence of an edema in the heart wall. Also, the T1 black blood for tissue characterization. These are a sequence carried out most of the time in prospective triggering during diastole and the form of one slice per one apnea. For the T1 or T2 with or without fat saturation are a classic turbospin sequence. This turbospin with a prepulse called black blood for more reproducibility and less of artifact. This is the diagram of the sequence. In the event of a fat saturation, we can use it's dependently can use steer or spare. The corresponding fat saturation pulse is also added. Here, the black blood effect is obtained by the fact that between the first 90-degree pulse and the 108-degree pulse, the circulating blood has left the slice, so no longer of the signal. There is no signal here. Sorry. The rapid method here, however, during slow circulation speed, it's the loss of black blood effect. In T2, especially, it's very sensitive to the cardiac motion. For the black blood turbospin sequence, we can apply a two inversion pulse of 180. The first, it's non-selective, invert the stationary and the circulating tissue, followed by a cutting pulse, which reinvert the stationary tissue within the inside the slice. The circulating, here we can get the signal collection. The circulating tissue blood still inverted within the slice minus 180-degree pulse. Is the most used method, more effective for slow flow. It's increased to do, we can have an increased signal from the stationary tissue with less sensitive to the movement or motion. However, increased also for the acquisition time, of course. During the setting, also check the direction of the face, always right, left, or anterior-posterior, never in head, foot. Check the size of the field of direction. It's the fob. It's still sufficient. We can make it around 300. Check the placement of the shim volume, and also check the quality of the ECG. If not, otherwise you can do to recap to do some calibration of the ECG, as I mentioned in the last session. Check the patient heart rate before and during the sequence. Refresh if necessary. You know to do this, how to do this. Click here so that the two value correspond to the possibility of a difference between difference of plus or minus 5. However, it can happen that the patient heart rate change too much during the sequence, in which case we obtain this. You see here the artifact. the consequence of cardiac motion during the acquisition. In this case, we manually enter the patient a maximum heart by going in this and clicking a left click, and we can go in the heart rate, and we can push this value in the heart rate maximum. This is there is here some image when we do some morphologic study. This is here the short axis. We see here the left ventricle, the right ventricle, and the septum interventricular. So here there is a case of pericardial effusion. We can see here a pair signal. Here we don't understand, especially if it is a septal edema or myocarditis. So we can see here some tumor in the T2 steer black blood. Here there is a persignal, and also here in T1 turbospinic black blood, we can see here an hyposignal. This indicates that there is a cardiac tumor. For the cardiac perfusion, the objective is to study of the dynamic of the myocardial contrast enhancement. We can see here the injection of the gadolinium, and we see the image how it's going during the sequence and the acquisition. Perfusion, also called the first pass study of the gadolinium. The goal of this sequence is to highlight the area of ischemia, for example, in the left or the right ventricle. We can choose by going to highlight this area in the rest or under pharmacological stress by injecting the adenosine, for example, to do some study in, we called it cardiac MR stress. Also to estimate the impact at rest or at stress of the stenosis. Also to highlight some area of hyperemia, especially the presence in case of myocarditis. Considering the sequence used in the perfusion, it's a classic BFF sequence like the CNE. It's but with a monophase, a single shot repeated with each heartbeat for approximately 1 minute while breathing freely. Good detection of airwave, this sequence. The number of slices also, it's related to the patient heart rate. Usually we can use between 3 or 5 slices. It's often used 3 slices in short axis and one in the 2 or 4 chamber. Maximum three in short axis during the stress perfusion. Yeah, if the rate of the heart is too high, we can get here a conflict in the foreign message appearing in the interface. That's tell you that there is a dynamic scan interval 1000 millisecond. It's a shorter than a dynamic scan duration. It's a message, so we can delete one or more slices when we appear this message in your console. So in this case, by deleting a single slice, the accessation will be possible. Once the slices are placed, we can see here the slices in the info tab. Check also the maximum heart rate. Here we can under 120. In this case, this is called one beat acquisition on a single air to R peak, ensure excellent temporal resolution. Make all slices here, make all slices into heartbeat or to RR set to beat. Yeah, I will demonstrate how to make this to beat. Just going to, when you see this error message, going to the first line, this is the conflict. To remove this conflict, click on line 1, just line 1, and replace 1 bit by 2 bit, and replace it to remove this conflict and the sequence going well. Yeah, you can see here that there is no conflict anymore. Or in this case, the coverage is, of course, it's improved, but the temporal resolution is degraded. For the procedure, just once they are placed, carry out new calibration, of course. Take an info that's the calibration of the VCG. It's very important each moment. Carry out a so-called blank perf without the injection in order to check the triggering and the possible artifact of unfolding. See if there is an interest of enlarging the FOV by maximum 8 to 400 or 350. The injection of the gadolinium, it's around 0.2 cc per kilogram of gadolinium at 5 cc per second. Start of the acquisition is in free breathing between 3 to 5 seconds after the start of the injection. Don't forget to inject the gadolinium supplement at the end of the infusion. During so-called stress MRI, carry out the new calibration of the VCG and the black perfusion. Here we can operate what we call the dark cream artifact. It's a magnetic stability artifact most are found at the septum of cavity interface. It here presents itself in form of a crescent with aposignal similar to apoperfusion, but it disappears suddenly on the following image. Apoperfusion is maintained throughout the sequence. If there is a delay in perfusion, the aposignal decreases slowly. Yeah, often appears randomly by is increased by too much of gadolinium or too low spatial resolution. Here there is some a picture of a perfusion and sorry and epidemia. There is the zone that indicates 1 and 2 slides. So one it's considering as a perfusion zone, and the 2 it's a normal zone. Yeah, here it's the post-processing for the perfusion. Just we select the sequence of the perfusion and we push the launch the MR cardiac analysis. Just also to verify and modify the labeling if possible. Just we take a look for the long axis in short axis or what we are used in the perfusion. And here we in the image we have right click and start the MRI analysis. Just here to set the first dynamic analysis and also to set the last dynamic analysis. We start by the first one and we finish by the last one. Also the possibility to show the registration inside the box. Here to put the heart inside the box. And if we want to have a maximum of view, just click right and to have a big box. Yeah, here we can do some contouring, undo contouring in the left ventricle. Also the epi contour in the left ventricle, and to place some repair by using these spokes. Just verify every moment that's the between 2 and 3 are faced in front of the right ventricle, and here we can get all the analysis and all the summary analysis by the left ventricle and the max and the time. Here there is all the curves here, the results that the doctors can choose or to estimate or to adjust some segment in the heart. And of course, there is some indication in this with these curves. Now we talk about the delayed enhancement. The objective is to precisely map the necrotic area of the myocardium by using some advanced sequence like 3D Dixon or the 3D PSIR, phase sensitive inversion recovery, or 2D PSIR in 2D. And by using also, we can use the 3D fast field echo in Philips. Here we can use multiple of sequence to do some delayed enhancement. Yeah, there is, of course, there is the sequence. It's carried out between 7 to 10 minutes after injection of double dose of gadolinium. For healthy myocardium, we'll have eliminated gadolinium. Necrotic myocardium still retain it. So by using 2D or 3D sequence, we can differentiate between in terms of contrast between the healthy myocardium and the necrotic myocardium. Know precisely if the enhancement, if this enhancement is called transmural, that's to say that exceed a half of the healthy heart muscle in terms of thickness. The sequence is carried out in prospective triggering and during breath holding in two cavity or four cavity and short axis, of course. For the 3D sequence, fast field echo, it's the most sequence used in 1.5 MRI machine. It's allowed in one breath hold of approximately 20 seconds to obtain between 10 or 12 slices. It's also required application of a very precise inversion time in order to perfectly saturate the healthy muscle. This time inversion in millisecond is found using a so-called T-scouting sequence called look-looker. The look-looker sequence is presented in a form of a single slice placed in the mid-ventricle of the short axis with a low spatial resolution. On another hand, a multiple phase with different T phase. So here we can applicate between the different phases. It's one to have one single slice, therefore another pulse of 180 pulse. TE it's separate time which separate 180 pulse from the acquisition of the phase in question. Yeah, what we are looking for is this precise moment. It's very important moment in inside it, the signal from the helium muscle is a zero. So to find the TE, once the sequence is completed, open it in the check table. Yeah, and we can go right click and to have array with free hand for all the phases and in all the slices. We can go to check the phase in millisecond here. And we can get the optimal TE in millisecond, which it's correspond the value of the signal the most low. So when we can get the signal the most low value, it's correspond the TE the perfect or the optimal TE. We can use the visual method just to find this image when the septal and some morphology appears very clear. Just 2 images later, we can find the optimal T or the time delay. Yeah, once the TE is found, just going to the contrast in the table and enter the found previously TE, to which we add between 10 to 20 milliseconds in order to compensate for the potential evolution of the T. Yeah, you can put this value here in the delay. Important, it's always remember that the T that is too short can side scare Here, I will explain this. When we use TE is too short, maybe we can see scale here. Also for TE too long, but see here the image, we can see that this is very important and an optimal TE used to have the perfusion. Yeah. A TE that's too long is less contrast. Here, you see here the contrast is it's less, but it's still okay, but it's still interpretable. Also for the 2D and 3D PSIR, file sensitive and version recovery, it's very often used at 3 Tesla. Also for the 2D PSIR, it's often used in addition to 3D fast field echo in form one slice per one breath holding or for more spatial resolution on apnea of duct, for example. The PSIR is a late enhancement sequence that does not necessarily require entering TE in order to obtain a difference in contrast between the health heart and the scale, for example, or disease in cardiac, myocardial. In the non-PSIR T1, the phase signal is always considered as positive here. It's therefore easy to see that very small difference in TE can have a major impact on healthy or muscle scale contraction. For the 3D Dixon sequence, Dixon is classic 3D FFO to which Dixon to have for picture in phase out phase acquisition combination is added. So it's necessary to enter the T value. It's a sequence of by using to 10 between 10 and 12 slices carried out in apnea. It allows you to have 2 to 4 image a better differentiation of the fat, particularly when it's in fact zone or during diffusive fatty infiltration of the heart muscle, especially when we focus of arterial fibrillation. SCAR can also provide assistance in the characterization of the pericardial disease or the characterization of cystic mass. Here, when we do the Dixon, we can get the water, the in phase image, out phase image, and the fat. This is what we can get from the 3D Dixon sequence. There is also the 3D T1 fast field echo ISO. It's getting by respiratory gating sequence and ECG triggering. It's used in particular for study of the atrial fibrosis. We can use it in the axial short axis or for chamber acquisition, and we can see it in free plane. As a sequence, it's so a little bit long, between 3 and 5 minutes. It's dependent on the spatial resolution chosen, as well as the patient, of course, and the heart and the respiratory rate. Do not hesitate in some particular to add between 30 and more 50 seconds to the TE measure. Yeah, here we can see the image of the 3D T1 turbo field echo ISO. It's an image acquisition approximately between 2 and 2 minute 13 in order to have an ISO in the 3 plane of 2 millimeter. When configuring the whatever method you choose, also check the FOV, check the placement of the volume, check the electrocardiogram. Here is some picture of location of the different enhancement. There is some different enhancement here appeared in the image. You can see here, so here the thrombus, it's endocardial enhancement in the wall. Here the intramyocardial enhancement image of the, and also here we can see image it dilated cardiomyopathy secondocardium to transmal enhancement. So we can see here the GADU and so on. Here for the infarction, we can see here the infarction of transmural enhancement. that black in the middle of the scan is not a healthy muscle. We call no reflow, would be due to the capillary obstruction between that's the GADU never reached in this area. Here we can see the post-processing for the delayed enhancement. Can choose the sequence of the enhancement on the short axis and launch the application. Also to verify and modify the labeling if necessary. Right-click on the image and select to start analysis image. Possibility for importing the contouring from the short axis functional short axis. Otherwise, create some undo or AP contour on each slice. Place markers here it's very important to place markers using green rays. So to segment to that the segment 2 or 3 in front of the right ventricle, the undo and the epi contouring as well as the position of the mark must be carried out or controlled on each of the section on which the analysis is desired. This envelope ensuring that a pair signal, you can see here that the pair signal are recognized such a type of enhancement here the pair signal by using the PSIR or the FFE sequence and recognized automatically, but not possible to correct if necessary. Yeah, we can double click to delete this image, and here we can get the results. There is here the table of the results of summary results of myocardial mass, the enhanced masses, of course, the percentage of the enhanced mass. We can get here the results of the left ventricle transmural index in percentage. Also the left ventricle enhanced. We can obtain also the binary enhanced volume percentage. Yeah, and we can get it if the undo or the AP contour enhanced in terms of percentage, of course. This is the tab summarize the enhancement delay in the subsection, so we can get to save this image. The flow study will move now from the flow sequence. We use the sequence key flow. It's to quantify the flow velocity in some vessels of interest. Here, we can see here the flow by giving a color scale for each movement. The Q flow, this technique is based on phase contrast to allow us to non-invasive and a precise study of flow. It's to provide a quantification of the information on the repercussion of valvular and vascular pathology. It's a robust method for little interoperative variation. Most of the time, single cut 2D or single slice 2D sequence was often carried out in apnea with retrospective triggering. The phase contrast is by principle when a magnetic field gradient is applied, moving acquire phase shift compared to the stationary spines. The phase shift will be proportional to the speed of movement. You can see the spine, it's static, and here we can see the position is related to offset. But when we can get a shift link into a position, we can see here the tissue in motion. Need to cancel the phase shift due to the position by using so-called bipolar gradient. When we use bipolar gradient, it's gradient composed by two identical bistrictal opposite gradient. It's by applying this, we therefore cancel the phase shifting period here. Yeah, after the acquisition, we obtain three images. the first image, it's the model image resulting from the subtraction of the signal from two parts of the bipolar gradient. And the second image, it's the image phase. That's R. This is the first image, and this is the phase image that's used for flow measurement and reconstructed by measuring the phase of the signal in the each voxel with a value equal zero in static tissue and different to zero in movement tissue. So we can see here the image of differentiation between the signal phase measurement. For the encoding speed or velocity, the sensitivity of phase contrast imaging is adjusted by using an encoding speed. In fact, this is applicating from 0 to 180 degree forward flow. For the forward flow, I can get a per signal in white, and the inverse it's a signal in black. Consequently, it's necessary to determine which speed in centimeter per second is the fast inside the slice. That's with which we can generate the greatest phase shift, therefore, for the mass signal. The artifact of aliasing is it's already a bad value of the velocity to, in this case, the speed giving a maximum of phase shift, and it's not the maximum speed, and the system assumes that this flow is reversed. So here we can see the aliasing manifests itself. It's totally white and or totally black. It's a reinvert pixel used right in the middle of the light. You can see here the image of the lines. Yeah. When setting, also to check the placement of the volume G, also to see the electrocardiogram. On the other hand, let the machine manage the direction of the phase. Also, no need to modify the FOV. During the setting, enter the encoding speed is close as possible to the actual speed in the vessel in order to obtain the most precise measurement possible. And if you want to adjust it in the dynamic angle and table here, we can give, and you can choose the speed as you want. There is here some parameter or some speeds for different vessels. Generally, for great precision, we start from a low speed, looking for the aliasing. Then we can repeat the sequence by increasing the velocity by 20. By 20, we can going forward by this step until the artifact is disappeared. Unencoding speed velocity that's too low or too high gives incorrect speed measurement, which gives us the aliasing. Yeah. And there is speed high here, there is speed too low. You can see the dark signal here and the gray signal here by using a speed too high. Its normal speed here, you can see in the vessel of interest a good contrast between the white or the black here. During this setting, place the slice strictly perpendicular to the flow, just to take it perpendicular to the flow that you wish to study, ideally using two perpendicular planes here, two perpendicular planes. Yeah, here the study of the fluid. This is some image. Yeah, always using two perpendicular planes. Place the center of the slice in the middle of the vessel in order to place the minimum. Around 16 voxels inside the vessel, which ensure a precision of at least 80% of signal. Do not reduce the number of phases below 16 to ensure a good visualization of the flow curves. Some particular sequence that we talk about the fluid and planes essentially used to visualize the flow, as well as its maximum speed. What we have just to concern the study of the flow, which which cross, of course, the acquisition plane. We therefore speak of flow through the plane. So we can talk about the totality of the fluid inside a slice. The study of plane uses exactly the same phase shift effect and to always place the slice in this particular sequence. It's to use the slice in parallel of the direction of the flow, and also to check that the flow coding or the velocity direction or the flow direction is also in the direction flow. Yeah, it's not the same thing that's the flow method. Once the slice is are placed in dynamic and angle table, change the velocity flow direction. So it's in the direction of the flow. We can hear this example of the aortic incline. Yeah, you can see to change the velocity in this, but change it in the foot head direction. We can talk about the morphology or the scene sequence. Here, when we talk about the flow, just you can use the foot head direction. The 40 flow, it's a long sequence around 10 minutes in cardiac and respiratory triggering. We can possible without do it without the respiratory triggering for the study of the aorta. It's a 3D sequence allowing the entire heart by studying the possibility of obtaining precise information on flow in three plane. For the post-processing is too long due to the required processing technique, correction of air link to phase and speed aliasing on each image. We can go for this post-processing for example, by using the circle or something like this. In Philips, we have a collaboration with P. We work with CAD-Flow. Yeah, here we can see the flow. We can select the image of flow to verify also the same things in the steps. And we have a right click on the image and start the application. We can choose the feed the contouring of the vessel. We can choose also the ROI as we want, and we see the different parts of different vessels we can work on. And there are a possibility to control or to modify some parameters and to propagate them inside all phases in the vessel analysis. And we can activate the background for the motion correction and so on. Yeah, here we can have array to have the background for the motion correction. And here we can get the curve of the analysis and summaries of all the parameters that you need when we're doing the Q flow. There is here some image for the Q flow in Philips. It's here aortic regression, and here the pulmonary valve and their curve. I will talk a little bit about the mapping because the time is going very, very fast. And the T1 mapping, T2 mapping, and the T2 star mapping. The mapping is to involve to obtain some parameter image of the different time relaxation that T1 and T2 and T2 star. These parameters, it's for the diagnosis and monitoring of the cardiomyopathy. For example, when edema leaks to increase and in T1 and T2, lipid infiltration, it leads to a reduction in T1 and T2, and iron overload leads to a reduction in T2 star. Generally, we use 1 to 3 slices, in short axis, 1 slice per apnea with ECG trigger. The calculating TY relaxation time, it's to have the myocardial T1 value for the measurement, and by using two parameters is T1 native and T2 and T1 enhanced. The objective is to have measuring the extracellular volume, and should be of course combined between native T1 and T1 enhanced. Yeah. As I said, we can see the T1 enhanced by applicants. So AMOLI sequence, that's its modified looker inversion recovery. And we do some post-processing. The difference between T1 and T1 enhanced, it's in terms of the acquisition of the configuration. It's during 5-second acquisition, 3 of break, and after that we can get 3 seconds of acquisition. And for the T1 enhanced, 4 seconds for acquisition and 1 from break, and 3T for the acquisition and 1 break. This is the paradigm of the acquisition. Yeah, the image is acquired during this different phase of the diagram and are recognized according to their respective T1. Here we are once the image is recombined, we obtain either some color image or a gray image, as we call it confidence overlay mapping, where is the cross out here in pixel shows with area with a value are inadequate. The extracellular volume is that are represented by T1 mapping. Time is going fast, so just a little bit. For the post-processing here, we can see the post-processing by have a T1 of native and T1 in enhanced. Yeah. The main objective of this is to obtain the extracellular volume, and we, yeah. Here we can see the image with the T1 native and T1 enhanced to obtain some, and here to check the quality, of course, and to do 3 rows in the liver, other row in the myocard, and to do all for the different slice. The other row it's in the myocard, and the last one is in the blood. So by going forward for all the slices, and we accept the segmentation here, we can get some parameters that summarize the T1 mapping. Here we can see the extracellular volume. This is what represent the main major objective of this study. Also for the T2 mapping, it's parametric to calculate some image and some in terms of milliseconds, and it's dependent for different parameters like 6H cardiac segment, generally used time in 1.5 Tesla between 50 milliseconds plus or minus 5 seconds, and for 3T Tesla we can obtain between 45 milliseconds plus or minus 5 milliseconds. For the T2 mapping, it's carried out mainly for the calculation of hemochromatosis. It's in normal value, it's greater than 20 milliseconds. For medium risk, if between 10 and 20 milliseconds, and in high risk, it's less than 10 milliseconds. Yeah, this is the parameter, and this included the post-processing. I will send them to you if you need, because no still time, as I think. When configuring the mapping, also check the direction, also the FOV, also the volume of shim, also the electrocardiogram. There is some parameters which depend very separately. For example, when you use TM mapping for amylose and filtration, it's very recommended. The T2, it's very recommended in the edema. And for example, when we can talk about the T2 star, it's very recommended in the filtration, also for the necrosis and for For the fibrosis, the extracellular volume, it's very recommended here in the fibrosis when we talk about the diffuse fibrosis or a focal fibrosis. Here there is a clinical reminder about the parameters one or the post-processing we talk about, and some normal or myocarditis, or when we talk about, for example, the iron also on, it's very important that he appeared very clear into 2 star. For the coronary, it's the study, it's the objective, it's to study the anatomy of the coronary artery. We can use some 3D coronary and wall art. It's to visualize the implementation of anomaly, the root anomaly, and the possibility of getting some stenosis or aneurysm from the sequence, possibility of carrying out 3D modeling of various part of the heart using some software, adaptable software. For example, in Philips, we use the MR art for modeling for example, when we modeling the pediatric anomalies for preparation or for some surgical procedure. It's a sequence on TT or 3T balanced turbo field echo sequence, generally accurate in axial plane. It's performed during the diastole and expiration to minimize the motion of the coronary artery. It's an isometric with a spatial resolution close to 1 millimeter. Can be done in 1.5 or 3T slam machine. The injection is not obligatory, but still possible. Yeah, here we can see the onset of the coronary, and we can this 3-track compensation. That's an acceptance of a window. Here we can see the window of the dome. Dome is defined. The center of the dome box is changed automatically in the position. The optimal positioning on the dome. We can put someone in the liver. The can see here in the bone of liver, and some parameter we can the gating window, for example, here modification in the gating window is not recommended, but we can move to sometimes we can modify the scale factor or something like this, for example, the length or in the trigger or the liver. Here we can get the signal, the ideal period for collecting a signal. Yeah, we can work in the 3 chamber or 4 chamber. Also, just I will take here very fast. Yeah, for the setting of the value, we can use trigger delay here, and the short duration. It's very important to put in the angle of the contrast. Here there is some picture of the axial acquisition. You can see the coronary here. Yeah, you can see the coronary here. You can see the right and the left coronary. Yeah, it's appeared very well here in the left and also for the right. Here some reconstruction and some the classic Kuru. Yeah, I think that's I finished, but there is it's okay. If there is any question, I will respond to
That's
them.
brilliant.
Thank you.
Abdul, this
Yeah.
Francis. I just have one question.
Yeah.
Yeah, about the T1 mapping. I saw that in your presentation.
Yeah.
You try to map the liver, the blood, and the myocardium.
Yeah.
Why is it so important to map the liver if your focus is on maybe the myocardium? Is there any reason why we have to map the liver? Thank you.
Yeah. Thank you very much. This is a very important question. You know, that's when we're doing the T1 mapping in terms of milliseconds. It's very important to consider that the parts of myocardium and the blood, and the third row it's in the liver. Just to put this row to separate in some calculation for the modelization of the signal, or to appear a good signal of the extra volume cell. We need this row as the third, which means that's no particular, or this row not involved in the heart study. This is why it's used in some signal modelization. So this parameter is very important to put it for some processing details. It's not equivalent as to have some indication of the heart, because it's very different, but for the quantification and the optimization, it's very important to include this parameter. Yeah, like you use array with fat sat or not inside some structure or anatomy, we can use this third row to do some measurement. Yeah.
All right, brilliant.
Yeah.
Thanks so much for the presentation.
Thank you. Thank you.
Yes, thank you very much. If there are any more questions, feel free to write them in the chat or raise your hand, and then I can unmute you. Yeah.
Marin, I don't think there's any other questions. Abdi, this was really great and fantastic. I have one small question. I think that we could end it here. This is a naive question, so bear with me. Sometimes one I think challenge with cardiac MRI or cardiac imaging in general is the fact that you're imaging a moving organ and you have to sort of compensate for that, and even use that information by gating, right? So what happens when you have situations when you can gate, or when you don't have let's say technology, you don't have actually the gating itself. Is it possible to still get some cardiac MRI parameters in a non-gated fashion? And if so, how would your platform do that?
What do you mean by gate? I don't understand.
So you have to like when you do cardiac imaging, you use ECG to gate.
You talk about triggering. Yeah.
Triggering. Okay, yes, triggering.
I
Yes.
understand now. Yeah, I understand now.
Yeah. So what
Yeah.
happens when you have a heart that has issues with triggering, and you may have to scan without triggering? Yeah.
Yeah. This is fantastic. Yeah. Without triggering, we can. There are two options of triggering: by using the ECG and by using the pulse PPU. In Philips, I talk about Philips. And there is in here, in this slide, you see that's in cardiovascular MR portfolio. It's our new innovation in Philips. It's the Vital Eye. You can see it here.
Mm-hmm.
It's detect with the AI, donc artificial intelligence. It's detect the breathing of the cardiac motion here, and also these parameter are during the acquisition. It's implemented during the acquisition in the console of the technician, and would be very, very, very useful in some cardiac disease and or inspiration or something like this. But if we have some problem in the ECG triggering, we can use the PPU, the pulse unit. It's similar to the ECG, but we can do the cardiac MRI in some sequence without the triggering. Of course, we can't go it because we still have some accusation that's included free breath holding, and also some of them okay that's are used with free breathing, but overall all the sequence in the CNE or the morphologic study and the perfusion we need very important. We need that's the triggering of the ECG. It's very important. But our innovation here in Philips, we can use the vital eye. That's detect with intelligence artificial the breathing of the patient and include them in the accusation. Yeah.
No, that's great. That's really great. I think somebody wanted you to, Anthony wanted you to sort of go over again why you're mapping. And actually, that was a good question, Francis. Why you're mapping on the liver when you're targeting the heart. He wanted you to go over the explanation again.
The mapping in the two in the liver. Yeah,
Yeah.
just for just for some measurement of, for example, when we do the homochromatism for example for the liver, just we take some rows inside the liver and some rows inside in the muscle of the liver and some rows just we need, for example, we need the background effect or the, without no signal. So just we put this ROI in the liver to do some measurement. It's all. It's not included in the T1 mapping, but it's to complement some measurement inside the rules. Yeah.
Thank you, Abdi. That's really great. And thank you so much. I'm glad that this has been recorded. So if anybody kind of missed that, they could go over again and review it.
Just for information, I will send the presentation for all the presenter that use Philips machine, and also I will talk with Francis to send some exam cards for who is very who them for the Philips. I want also to understand and to know for some participant here which machine works on, and I will send them and I will help if they need me for some situation, and I will explain them. And for the mapping also, I will do some post-processing for some who needs very much the post-processing. Yeah.
Oh, Abdi, this is fantastic. Thank you so much. So what we do, Marina can put together a list of the participants and highlight the ones that have Philips and send it to you.
Maria, she's already sent me the list. Yeah.
Oh, she already sent it to you. Okay, so you and Francis can work out what you discussed, and this is great. Thank you so much. I know that Francis, I think you have a site in Ghana that has Philips, right? Is it Toshiba? I don't remember now.
Yeah, I think some of them have Philips as well.
Philips.
Yeah.
Okay, yeah. So you and Abdi
just take
can...
my contact, and we will discuss after that. And if you need for the acquisition and also for the post processing, I will give help, of course.
Yeah, that's a good call. Yeah.
Yeah. So I'll forward the WhatsApp to Francis, and then he will take it